So market by market, the composition of the demand for services and the provider of services looks a little bit different. And that level of precision and nuance can make or break certain organizations. That could be the difference of reallocating your sales team resources, right? And where you're kind of selling. It can change your recruiting practices for bringing on certain provider types. It could change your marketing approach to how to educate patients that some of these services exist, right? There's a lot of downstream implications, but it starts from getting down to a more precise understanding of the nuances within that supply and demand, which is something that I find leaders are not fully there yet and really asking those types of questions.
Hello, everyone, and welcome to another meeting of the minds. Quick background for Sanjula. Sanjula Jain is a healthcare economist who advises C-suite and senior leaders in healthcare on how to best use data and economic insights. She's the chief research officer for Trilliant Health. She's a podcaster. She's one of the best data storytellers that I know, and she uses these insights to help leaders like you to challenge the status quo. Her recent report, Trends Shaping the Health Economy, Behavioral Health, combined data from commercial payers, Medicare, Medicare Advantage, and Medicaid for a thorough analysis across around 300 million people of the most recent behavioral health trends as of all the way up to this year. So among many things, the report covered how increased demand is straining the system and many of the disparities of that impact. Sanjula, I just want to start off a little bit on the personal background, because I know you have a really storied, a big story in leadership in market development, research, and health economics. And I want to zoom in a little bit on the healthcare economics piece. When going through this study, what kind of impact are you hoping to have on the healthcare industry by releasing this research and publishing?
Yeah, so Chris, maybe to answer that, let me just zoom out for a second, because I think the kind of agenda that I have for all the research that my team and I put out, including behavioral health, there's kind of a central theme. And that theme is I come from a background of working with, you mentioned it, executives, of health systems and payers and, young companies. And across the years, I've heard a central thesis from these leaders where a lot of their decision-making perspectives were informed by anecdote, assumptions, their best guess, a concept of best practices, learning from, others, and it's all well intended, right? Healthcare is complicated, as we all know, and so there's a lot of change, there's a lot of complexity, and we're all just trying to navigate and grapple with all the different dynamics and headwinds that are coming at us. But the way in which we are synthesizing and trying to contextualize, okay, going forward, how do we prepare for the future, right? If I'm going to make this investment in a teletherapy, program, right? What is the potential ROI on it? Or what do I know about the potential patients who are likely to consume it, right? And we all make, our best informed, decisions around, let's assume X% of the population has this condition, and so therefore they're likely to use it, right? That's kind of been the way in which we kind of operate. And I always felt that, well, there has to be something more rigorous. And so to my health economics background, right, I trained in academia, I still teach part-time over at Hopkins, right? So I appreciate the rigor that a lot of my academic colleagues are putting forward and really studying things at a national level or policy level to really understand what's happening in the environment. The limitation, though, in kind of the academic policy world, probably two things, right? One is recency. It's no surprise that healthcare data has a huge lag typically in the industry, right? So when I was in academia, I could be publishing a paper on Medicare policy or telehealth or behavioral health, and I'm still looking at 2 years old data, right? Then by the time you go through the peer review process, you're looking at really 3 or 4 years out by the time you're actually reading it. Then you take into the factor that most executives who are making these decisions that have the ability to make our healthcare system better, do they read JAMA and others? For sure. But is that their primary reading source day to day? Not exactly. So my mission has been to try to bring some of that rigor and scale to some of those academic research principles in a way that is more relevant and kind of actionable for executives. And so the behavioral health report really is part of an ongoing series that my team and I kind of put together. And it stemmed from, we could all agree there's no doubt, there's no question that the United States has a severe, significant behavioral health crisis, right? So the purpose of this report was not necessarily just to re-quantify the magnitude of that, right? There's a lot of survey data, the CDC has numbers out there, so there really was no need for that. But one of the gaps that we observed was, well, okay, we have this crisis, we have finite resources. Where is the puck headed, right? What is the magnitude of this issue? What is the rate of change? Are there any changes in behavior at the provider level or patient level that might be indicative of things that might signal where things are going forward? So the premise of the study really is taking a longitudinal view to track patients or individuals that are getting behavioral health care in this country before the pandemic, so from kind of 2019 through 2022, and to really look along those stages of their journey. What are they doing differently? What has changed? What has grown? What has amplified? And really just give the market and the industry a baseline to really kind of take a step back and say, okay, what do I think this might mean for the future, and where do we go from here? The report is organized into 3 sections: supply, demand, and yield. And at the end of the day, we're all trying to improve the health of Americans, but we also have finite resources, right? And there's economic considerations we have to factor into how we, juggle these priorities and what we can do. And so the trends really kind of take that, from a demand perspective, what are the diagnoses, what are the conditions, what are the patient preferences for settings of care that's really underlying the demand for behavioral health care service use. But then look at that in tandem with, well, are there supply side trends that are maybe different, right? Or what are we seeing in terms of, behavioral health providers delivering care versus primary care? What's the role of new entrants versus traditional health systems, right? Is there a difference by geography in both supply and demand trends? And then, of course, as we all know, the intersection of that is really your yield, right? And so what ultimately influences supply and demand are cost of care and price, and a lot of the policies that we're all kind of operating within. And so that framework, I'm hoping, gives folks a lens to inform your own opinions. So if you are an organization really focused on the supply side of the equation, you're probably going to really resonate with the supply side. But my caveat is, it's really important for you to still have familiarity with the things that are happening on the demand side too, because I think one of the challenges we have in healthcare is we tend to think a little bit in our own silos or focus on our piece of the equation. And this is really meant to hopefully, help you zoom back to say, oh, look, these are our challenges and our realities. I have to solve that in the context of what's happening on this side of the equation as well.
Great. And to help illustrate more around that equation and this overall structure that you're taking, could you give us an overview of some of the key findings across those 3 buckets that you mentioned?
Sure. So I think the first finding, no surprise to anybody here, is that we've seen a shift in setting of care in which Americans are receiving behavioral health care services. And that primary shift we see is towards virtual care and telehealth. That's probably an obvious finding. That said, the reason I share that is because when you start unpacking that trend further, it's interesting to start looking at, okay, what are some of the downstream implications of that? The related findings, and we'll connect the dots on this in a little bit, is, well, for starters, we're seeing that more Americans are using medication for behavioral health than we've seen previously. We are seeing younger Americans not only present with more diagnoses, right? So individuals under the age of 18 relative to the entire US population have a disproportionate share of eating disorders and depressive disorders. The younger American population is disproportionately affected, and that medication trend also applies to them. And then when you kind of look at the supply side, well, we see the intersection of the high demand that's resonating with the new settings of care and telehealth is that because we have a provider shortage of behavioral health specialists, we've seen primary care really absorb a lot of that demand. And so we see a lot of the tele-behavioral prescribing come from primary care, which we'll come back to. And then on the yield side, the third piece is when you start looking at those longitudinal journeys, what really emerges is that while the incremental cost of delivering certain parts of behavioral health care, right? Like, so if you use a virtual care therapy session, right, the economics of that are kind of favorable relative to an in-person, visit in terms of the cost of care. But when you look at what the patient does next and all the things in terms of their comorbidities and their prescriptions and everything else that they're doing, we see that the total cost of care is actually increasing, right? And so that is something that poses a great concern. So when you put demand, supply, and yield together, what we're seeing is we have growing demand, and that doesn't even account for policy provisions on the table around potentially changing screening requirements, right, in this country, which could further identify more individuals with these conditions. Constrained supply, right? And even though the new entrance in telehealth has been a way to scale some of that supply still can't meet the demand, right? So we still have a mismatch there. And economics 101, right? When we have demand exceeding supply, what happens? Price and costs go up, right? And so it sounds really basic, and there's a lot of individual findings within all of that, but that is something we really haven't talked about as a nation from a policy perspective, a public health perspective, a care delivery perspective of how do we start curbing? We already have an unsustainable healthcare system, right? From a cost perspective, let alone health burden perspective. And so if we are already seeing costs going up, which we can kind of pinpoint to some of these pathways, and we know we have high demand, what do we do to start paring that back from a health burden and cost burden perspective?
Excellent points. I mean, there are all kinds of factors that are helping to drive up that demand, make people even more aware of issues they might not have even brought up 10 years ago or been ready to confront. It does seem like there has been much more of a conversation that's driving that's assisting driving that demand forward. And of course, the mass trauma that we all experienced at the same time with the pandemic and the cluster of events that have happened since then.
One of the more disheartening findings kind of early on, before we actually formalized the study, right, is something connecting the dots between pharmacy trends and medical trends, right? So to that point, we saw during the pandemic that there are more prescriptions for Adderall than there are diagnoses for ADHD, right? So that's kind of interesting. I'm not a clinician, I have to preface that, but just looking at that from a data perspective, I say, well, okay, I can probably explain that from a pandemic perspective, right? We were all forced into our homes. Children were doing, homeschool. We're all working remotely, and there were a lot of pressures and changes to how we learn and think and process and focus. So we could probably see why the use of Adderall went up, right? Like, you can explain that from a demand perspective. But the question is, what should that new normal be going forward? Is that a clinical concern that we have people taking medications that really haven't been seen or kind of officially diagnosed by a behavioral health specialist, right? What does that mean in terms of protocols that we may want to consider or may not want to consider as it comes to how we prescribe behavioral health therapies, or how do we triage and think about which patients see a behavioral health specialist, knowing we have a shortage versus, what are the things that we think primary care providers should be treating, right? So it kind of introduces a whole host of questions. And then I pair that back with, well, if we have a younger generation of individuals experiencing these diseases and on these medications, right? And I'm just looking at the science, you read all the propensities for developing side effects, right? And so if you are taking certain stimulants, for example, right, your risk of certain heart conditions and other things go up. So I'm thinking, right, conceptually in my head, okay, so if you now have, for argument's sake, 10-year-olds, more 10-year-olds or 12-year-olds, starting some of these drugs earlier on in their life than historical norms, and you compound those risk factors over time, will that increase their development of additional comorbidities, right? And does that increase the cost and kind of overall health needs that individual presents 10, 20, 30 years from now compared to maybe kind of what we're used to seeing today, right? So these are clinical questions, right? But some of these initial findings, to me, really I believe should start posing those questions for the industry to really think about, what do we want the new normal to be? And it starts with, what does the ideal pathway look like?
Yeah, these clinical questions, they give rise to administrative and policy questions. And I think that one major aspect of your role is not just in the production of these reports, but also in the communication that you're doing across various sectors in healthcare. As like our audience, the folks that typically come to Meeting of the Minds, we have a lot of folks on like the clinical or behavioral health side, but there's also a lot of people that are serving in population health or as operators or strategists within the healthcare system or payer domains. Just curious about, like, you've put out this research, you put out this data. What's been some of the tone of the conversations, knowing about this increased demand and constrained supply? What are the conversations from the folks that are out here operating and making decisions here?
I'm not an expert, but from what the data shows, the reactions I've gotten from the industry is, okay, well, despite being an expert and despite, thinking about behavioral health every day and either building a product for it or thinking about, the payment model for it, I had not really connected some of these dots, right? And in isolation, the fact that demand is going up makes sense. But then looking at that from the lens of what that means for prescriptions and if certain markets have a higher or lower demand is something I had not thought about in terms of, what does that mean in terms of my footprint? Where do I need to find behavioral health specialists? Are there certain behavioral health conditions that telehealth is being used more or less for, right? So one of those things that we find is, lower acuity conditions are better served with telehealth versus in person. And I share that because there were a couple of investors who said, we've invested in some really powerful, digital health providers, in the behavioral health space. And they're not really seeing the same level of kind of financial success that we would have anticipated, knowing that we have this behavioral health crisis and demand is growing. So for them, it didn't quite add up. But until they started peeling back the layers and said, well, actually, okay, that particular company was really focused on more higher acuity behavioral health conditions, right? And so it was, well, most of the kind of preferred use by patients tends to be for more of your anxiety and depression, not so much some of the more, serious conditions. And so there is a mismatch that's happening in what the service is relative to what the demand actually is, right? So, that's been an interesting perspective from an investor point of view of really thinking more granularly about what the market is for very specific solutions. I think the other reaction has been interesting is on the pharmacy side, actually, right? So looking at some of the prescribing trends, what are the characteristics of the patients, not only the patients using them from an age or demographic or location perspective, which is really relevant when we think about some of the headlines that emerged months ago around cerebral and prescribing practices and things like that. But also, are there any interesting characteristics about the physicians or the providers that are prescribing certain medications or the ones that use teletherapy more than others? So I would say, to directly answer your question, Chris, it's really kind of led to a lot of aha moments and have people kind of really just take a step back and say, okay, oh, this might start explaining some of the things that we've been seeing. And most importantly, it's led to a lot of follow-up questions. And so a lot of what my team is doing, has been doing in the last couple of weeks, really has been going deeper into a lot of these trends for specific organizations to really double click, right? So now, we know demand by kind of macro condition category, what those numbers look like. Well, is there a difference between this specific code versus that specific code, right? Is there a difference in a certain brand of a medication and, someone who's prescribing more or less of it? So a lot of double clicks are starting to happen. And I think that's really helping the market have a more informed baseline of, where the opportunities are, where the common challenges are, but really like what the size of the opportunity actually really is. I think that's recalibrating expectations a bit.
So great point to bring up around like how once you produce a report or you produce this assessment, I think that it's a great sign of success when you start getting those deeper follow-up questions, those kinds of double clicks there. A lot of what you identified is that the type of demand that's increasing, the inventories and the supply that was available, there was a mismatch in how to address that specific type of demand.
The fact still remains that like across the board, right, we just don't have enough supply for that demand. The next layer of that is, okay, if you take a given market, so I'm in the DC area, right? If you were to just look at a market specific level and you look at which conditions and which patient cohorts are driving the most demand for behavioral health services, and then also ran a similar analysis to look at, what are the most common provider types delivering that care, right? And what percent of that care is virtual versus in person? Those numbers for the DC market would fundamentally look different than what it looks like in the Atlanta market or the New York market, right? So market by market, the composition of the demand for services and the provider of services looks a little bit different. And that level of precision and nuance can make or break certain organizations, right? Like that could be the difference of reallocating your sales team resources, right? And where you're kind of selling. It can change your recruiting practices for bringing on certain provider types, right? It could change your marketing approach to how to educate patients that some of these services exist, right? There's a lot of downstream implications, but it starts from getting down to a more precise understanding of the nuances within that supply and demand, which is something that I find leaders are not fully there yet and really asking those types of questions.
Huge point, because if we keep it vague, if we keep it general, if we only look at those national headline numbers and craft our strategies based on that, you might be looking at something that's weighted towards the biggest population areas in the country and not applicable to your particular region. And we kind of see that too when we're like doing assessments on conversation flows and patterns across various regions, age groups, demographics. We need to be in an era where we ask the deeper questions on, okay, well, we understand the broad trend, but how do we dial into the individual segments and personas within our markets?
Yeah, and I think, it goes back to like public health and like pop health things that we've been talking about for over a decade, right? Like we all say healthcare is local, right? We all talk about the communities we serve, but yet we're not really applying that principle to how we're really looking at data to make some of these decisions, right? And so, I started by saying I don't even think we have a good understanding as a country of the national baseline, right? And kind of connecting those dots. So you first kind of have to have an understanding of what's happening there and then peel it back to a regional view and then look at from a benchmark perspective, right? Are you in a market that is on par with other markets, or are you, above average or below average, right? Are there certain things that are common between, certain markets that maybe could facilitate learnings or identification of certain strategies that work, better or worse for that specific patient population, right? We know that how we might manage the behavioral health care of a specific age cohort is going to look very different than another age cohort, right? But that age cohort could have differences by ethnicity or gender or other things, and right, there's so many layers to this that we can make a lot of assumptions around, and I think that's another mistake we make, right? I hear a lot in the market of, okay, well, for our Medicare population versus our Medicaid population, we'll think about it this way versus our commercial population. We can't think about populations and strategies just from a payer segment perspective because there's so many more layers beyond that.
Yeah, it really hurts my heart a lot of times when I see the nature of different strategies and approaches based on payer population, income, and things like that. You've done a great job in terms of taking really complex data insights and making them really accessible within that guide, within the behavioral health trends guides. I wonder, just in your conversations and your interactions with healthcare leaders, what are some skills that leaders should be thinking about leveling up? Like what to be able to understand and work in more of a data-driven world, which not all of us have been trained in, not all of us have that background. What are some skills that can help leaders to start making better assessments and decisions from these data-driven approaches?
Yeah, I think the disconnect, if I can be so bold to use that word, comes from kind of this misconception of buzzwords, right? And so most executives I talk to, and I'm sure Chris, you come across this as well, they all say, of course we're data driven, right? We have so much data and we think about it this way and we do it that way, right? So I think when we say data driven, you know, everyone has data in their organizations, right? And how we use and how we think about it is one thing. But I think what I see as kind of really differentiating the more progressive leaders in the space who are really connecting that to strategy and decisions are those who are actually not taking things at face value, right? So let me give you a little bit of a broader example than behavioral health. So around the telehealth times, right? Most CEOs of health systems that I would talk to at the time would say, oh yeah, our volumes in our organization are 300% greater and all of that stuff, so it's going up and so therefore we're doubling down on it, right? Like they would cite numbers that are either limited to their organization or something they saw in a headline, right? Now some of those headlines, and I know this is a little bit of a wonky technical way to think about it, but I think it's important, right? Some of those headlines were looking at surveys of 100 people, 500 people, right? And we were making, it's like back to some of the economic principles, like the 80-20 rule, right? We were making decisions that were reflective of 20% of the population and extrapolating it to 80% of the population, right? And so I think that's a lot of the common mistakes we make. And so it starts with leaders actually taking a step back and asking the question, okay, well, where is data from? What population is it representing, right? Number one. Number two, what are the benchmarks, right? So, back to the health system citing, my organization has, 300% more. Okay, well, is that 300% relative to what? What was the starting point? How does that number compare to other health systems? Is that number different in your geographic region versus another geographic region, right? Are different patients driving that number versus your competitor down the street using a different number, right? Are we comparing apples to apples numbers? So sometimes I hear, oh, I saw a headline saying that payer X, Anthem or Elevon, somebody, Aetna is doing this and they're seeing these numbers. Well, those numbers could be representative of one condition or one patient population, and then we extrapolate that to a benchmark representing a different set of conditions, right? So it can be highly technical, and I don't think it means that leaders have to be technical. It just means that before we just blanketly cite headlines and statistics that we see around, and there's a lot of them out there, I recognize that, and it's complicated, we should really just ask the question, right? Like, is this data valid, right? And is it, what are the limitations of it? And I just don't, if we ask that even 10% more of the time, I think we would see a radically different conversation and level of thinking in how we make decisions.
100%, Sanjula. And I think a lot of this is about confidence too, because there might be some explanation or something that might not sit well with the leader, but they've been ingrained with this message, oh, I have to be data driven. But not being a data professional, not having that background, they might be afraid to speak up and ask the deeper questions about, well, how is it, like, is this applicable to our market? Part of the conversation that we were having earlier was around how a DC strategy might not be applicable in Atlanta. So maybe there's a step above data driven where we get back in the driver's seat and be data informed and understand how to ask the right questions.
I think that's very well said. The other thing you got me thinking, I'll share something that just happened over the last month or so. So I've been on the road, as you know, speaking with a lot of different organizations, providers, payers, technology organizations. And I will tell you that there are some instances where I will, run an analysis showing how that organization is performing, right, on X metric, or it could be their market share for behavioral health or things like that. And sometimes the leadership will say, well, that's not what we see. And so we'll go through the specs of, how they calculated their numbers. And I go back to sample, right? Sometimes they're calculating things based off assumptions and not having full visibility, right? So we reconcile the numbers and they'll say, and usually the number I'm showing shows a lower number, right? Like signaling some lower performance. And sometimes leaders will say, well, I can't really show that to the team because it's going to change the strategy or what we decided 6 months ago, and we're going to like press forward. And I hate to say that out loud, but that is very much something I hear more than once. And I think that goes back to we're moving fast. There's a lot of responsibilities and tough decisions, that our leadership have to take into account. But we also spend a lot of time making these plans. We do strategic planning once a year, and then we're not really tracking a lot of these things and seeing, have assumptions change. Should we adjust in real time, right? I see this, being in DC, I think a lot about policy, right? We saw this during the pandemic, right? With telehealth, it's like, oh, we saw this peak go up here, so we're going to make some, think about it this way. But we haven't really looked at saying, well, and is that a permanent change? Is that a temporary change, right? What does that mean? What did the level of utilization change when we made this policy provision versus this one? Instead of waiting 2 years to go analyze it retroactively, like to be tracking it even at a quarterly level. So I think it's being informed. I love that. But I also think it's the willingness to go back to your team and say, hey, maybe this picture doesn't look so great, but what are we going to go do about it? Because the reality is it probably isn't a good picture half the time, but that's how we're going to make the change, right? We have to be honest with ourselves of where we actually stand. And I think that's step one.
Yeah, that's a leadership lesson in general, is to not blind yourself to the real world just because of past investments. And we could keep going on this topic, but I want to maybe pull a little bit of a layer back too, because we have the ability to ask these questions and interrogate the data and sources and everything like that. But there's a problem that happens when you do something and it confirms something that you already believed and you think that it's answered and you move on. That confirmation bias. How do you avoid the temptation of just going down the path of something that already confirms your beliefs?
I could argue you could find some source to validate almost any viewpoint out there, right? And so it's a matter of go find the counter opinion, right? And go get 20 opinions or go get 20 sources on the same topic. Think about it from a different stakeholder perspective, right? So you might have found a finding or a data point that validates, what you think your direction or your assumption is, but maybe if you take a different lens and thought about it from a competitor point of view or a different stakeholder, you might come to a different answer, right? And I always think about, how would somebody try to poke holes at this, right? What questions would they ask that I would have to defend, right? So I think it's getting a lot of inputs, whether it's talking to people as well as getting hard data from multiple sources and questioning the methodology and trying to put them together, right? That's a lot of what my team and I spend time doing is we reconcile 20 different studies on the same topic. And we're like, this person came up with this number, this person came up with this number. Can we really compare these two numbers, right? Like what are the pros and cons and the sample size and things like that. So I think it goes back to what we talked about earlier.
Well, I hope that people watching can come away with a sense and a confidence to ask more questions and interrogate much deeper. What's your advice to people that are working in these teams that want to bring more data-informed leadership to the table?
It's interesting. A couple of years ago, I remember sitting down with an executive at a large retail, organization that we know very well. And he had said, in every meeting that we had, whether it's an internal team meeting or a weekly leadership meeting, we all start the meeting going around and we have to share we have to use data to give our progress update, right? So, last week sales went up X% and we saw returns by this, and this is what we know about the customers who did for this return, right? Every single person or functional area had to communicate with data, right? And so that got me thinking, we don't really do that in healthcare in particular, right? And so my advice would be, I think we have to lead by example, right? So back to what I do. I don't have an opinion on how we solve the problem right now. I'm not an expert in operational how to execute the strategy, but I can provide the information to help people think, right? And so I think it's the same mindset of, if you feel confident in the number and the factual base that you're putting forward, pose it back as a question. Say, this is what we're seeing. These are some of the things I think it could mean. These are the things that it could not mean. These are the strengths, these are limitations. What do you all think, right? It's kind of framing a lot of the data and the evidence in a way that'll get a conversation going. And it's really just it's a thinking exercise, right? And some people might poke holes at it, some might challenge it, but there's going to be someone who's going to be like, even if they don't say it, it's going to change how they're thinking, whether it's subconsciously or consciously or in that moment or a week later. So I think it's easier said than done, but I think it's just leading your conversation or supporting your viewpoints with data points where you can, and pose the questions back.
We just have to understand that the quality of an organization depends on the quality of the decisions that underpin it. So you need a quality source for those decisions to happen. We've kind of painted this picture around the behavioral health landscape and economy overall, and these frameworks, these ideas on how to make decisions based on that. Could you talk about how organizations should monitor their own success? Like, are these decisions actually working? Are we doing well and performing in the market?
I think that the starting point is, what is the objective, right? So who is our customer, right? And I know we all have standard measures that we're used to thinking about, right? The balance sheet, revenues, if you're in the provider business, you're thinking about HCAHPS and readmissions, right? Like, we all have, healthcare has a lot of measurement systems and metrics, right? And I would say put that aside for just a second. Put away all the traditional measures that we're expected to produce, right? Who is our customer and what is our objective that we are trying to achieve as a business? And I think it's being really honest about what that is, and then how are we going to hold ourselves accountable to that measure. So if we are trying to reach more patients with behavioral health services, right? If the starting point is today we deliver behavioral therapy to 2,000 patients, right? Have we grown the number of patients we're seeing, right? And actually put that as a benchmark. It's like Donna Bedian, right? Structure, process, outcomes, right? What are the mediating factors that we're developing strategies around to get the outcomes we're trying to do? And then how do we measure if they're actually working, right? So if we're trying to look at engagement, right? We want patients to see their provider multiple times to have continuity of care. Has their visit interaction changed from 2 to 5, right? So there's endless number of examples, and I know it sounds really basic, but it's every day I have conversations where sometimes it's like we get down rabbit holes of multi-billion-dollar organizations talking about HCAHPS and this, and they're talking about consumer engagement strategies, and it's like, well, have you even just measured share of care? What percent of all that patient's care are you even seeing? Right? It's like we don't even orient ourselves that way. So I think resetting on a different set of metrics is step one. And then step two is to really think about, okay, now how do we go calculate that metric? And sometimes calculating it means you don't have the answers from all your internal data sources, right? And I think that's also a new way of thinking, right? What is the right benchmark, a comparable benchmark, to see how we're performing relative to something that's comparable? If I'm in a traditional provider business and I only see my EMR, there could be things happening outside of my EMR that have implications for my patient population. I should probably go figure out what else they're doing to have a fuller picture before I, determine if I'm performing well or not on my metrics.
So that really that lies parallel to some of the more recent research that you put out that looks at these kinds of benchmarks and explorations.
Well, it's building on the same theme, Chris, of everything we've been talking about, right? So the quick thing on hospital benchmarking, back to how we make decisions. I can't tell you the number of times I've been in a room with a hospital executive that says, I want to be number one on US News, or I want to know what Mayo is doing. I want to know what Hopkins is doing, right? And it's always like, okay, but why? If you're a hospital in Dallas and you have a very different population, what can you emulate from, the Mayo Clinic, right, which has a very different patient population geography, set of services, and endless number of other factors, right? And it was kind of this apples to apples comparison. So, in short, we've really developed an algorithmic approach to basically take any number of comparison metrics, a lot of the same metrics that we're used to in things like US News and Leapfrog from a quality perspective, things that every hospital is already reporting, but it's taking the subjectivity out of it and showing you who should I actually be comparing myself to, what are the right benchmarks, and then what does performance look like. So that's kind of one big thing about it, and it's called the similarity index hospitals, right? So it shows you your similarity and then you index against a set of measures. The second piece, back to measurement, this is actually a really great segue you made, is we've been primed to think about quality in a very defined way, and right, and that has an important role in how we all operate. But if you actually look at the spread of quality metrics for a set of hospitals, it's it's not very long, right? Like to go from a 94 to a 94.5, like they're really small differences in a lot of these measures. I'm not saying it's not important to focus on that, but back to strategy. We're investing a lot of money into a lot of other things, and ultimately our revenue comes from things like market share and how competitive are we and what services are we offering, right? It's more than just quality, right? We're accountable for a variety of measures relevant to our business. And so the index also accounts for measures beyond quality to help hospital leaders really think differently about what do we need to succeed going forward and what are a range of benchmarks. You could be really great in quality compared to some of your peers, but not be as great from a financial performance perspective. And you kind of need both, right? You need multiple things to be successful. So it kind of builds on a lot of what we just talked about today, where it's challenging the way that we've done things for so many years, and sometimes we don't even know why, and taking a step back to say, what's the goal? What's the objective? Hospitals, I mean, there's no secret the US healthcare system is terrible, right? We have to improve it. And clearly, year after year, we put out these ratings and rankings, and we pat ourselves on the back to say, I got this award. Did it actually make a difference? We're sitting here talking about how to improve the healthcare system, right? So let's flip it on its head, and let's try some new things and make it more data driven to really get folks to challenge their assumptions and get out of their old, anecdotal ways, and see if that will help give a more tangible way to track, are you improving and where should you focus your efforts?
And speaking of flipping it on its head, that really that kind of plays into a question we just got from the audience, which was just around, in these conversations with leaders and executives, was there anything that gave like a hint of optimism at like how people are making decisions, or any kinds of changes people are making based on this data?
They call me the gloom and doom lady for a reason, because I feel like right now a lot of my data is saying some not so great things. I wish it was a different story. I think it's still early. I do think there are a handful of leaders who are thinking differently about some of their investments and are maybe kind of paring back a little bit. Not to say that they're not prioritizing behavioral health, but they're maybe investing differently. So let me give you an example. I think there are a handful of companies who are focused on the supply side of behavioral health, right? And they're realizing, well, we actually have the same issue that traditional providers have. There's just a shortage of psychiatrists. Whether you're a telehealth company or a health system, it's the same resource we're after. Like, one can't produce more of that resource than the other necessarily. And so maybe thinking differently about the business, okay, if we're limited in our growth for this period of time by X number of psychiatrists, are there other things we could be thinking about to encourage more people to train, right? I'm not saying that folks are doing this necessarily yet, but I think a handful of leaders have started to think, okay, maybe we can't solve this right now. We should, focus efforts a little bit differently and, shift gears to A, B, and C, or, how do we get more involved in the education front and things like that. So I think it's still early. I think this is a huge issue. I think it's a huge challenge, and there's no easy solution. And so I think it's going to take a little bit more peeling back the onions to really think about, what does this mean to do differently? And ultimately, it's going to have to require people coming together, right? The policymakers and individual, digital health providers and investors, right? Everybody has to kind of come together to think about which piece of this continuum they're really going to go tackle.
Folks who spout doom and gloom, I'm going to say it, can sometimes be underappreciated. If someone thinks that everything is fine, then they're going to be less inclined to do any kind of action. For you, the queen of doom and gloom, as you said, I'm going to give you a magic wand. We ask this question for everybody. You get a magic wand that allows you to change a single aspect of the United States healthcare system. So what would that change be?
I think that a mentor of mine had mentioned this, that, the system is working the way that it was designed, right? Which is an interesting thing to think about. And a lot of that comes from the policy structures and the incentive structures we have in place. And we'd have to spend 3 hours unpacking that alone, Chris, right? Whether it's things that we have around MLR provisions and what that means for what insurance companies can do, or how we determine RVUs and billing, or even some of the value-based payment models and how those are designed, or HCAP metrics, or how we develop employer, health benefit networks, right? There's endless number of examples of the policy incentives and the payment structures have manifested in the way that they were really intended to work in pieces. And so if I had a magic wand, I would almost take it all away and start from scratch, right? I think we almost have to create a whole new set of measurement standards, right? And I think that we would shift our thinking from, instead of thinking about value-based care, we think about value for money, and we think about quality relative to price. And we would just change our orientation on a lot of things. I remember in my PhD training, I had a professor who was involved in the early years of coming up with the methodology for RVUs and some of the payment models for different specialties with one of the committees. And he had said that there were points in the conversation where you'd have, physicians and specialty groups around the table, and they would say, oh, I use more of my brain, or went through more schooling to be a neurologist or a cardiologist versus primary care, so my rate should be higher. Now, this is anecdote. I heard this from a secondhand story, right? But that kind of stuck with me of, how do we make that decision? What maybe worked back in the day, does that really still hold true today? Now we have a primary care and behavioral health crisis. What does that mean for the payment model and how we incentivize individuals to go into these professions, right? So we could spend hours on it, but I think it really would be starting fresh on some of the reimbursement and financing structures that we have today.
Beautiful answer. It really goes all the way down to the heart of the matter. I hate to close out this conversation because it's been so real. For folks that want more of this, for like this hour was not enough, what is the best way that people can reach out, get in touch with you?
Sure. Folks can certainly reach me on LinkedIn or Twitter, just Sanjula Jain, or shoot me a note at sanjula.jain@trillianhealth.com. But would love to hear any questions or thoughts you have. I'm here to help, and ultimately I'm just an academic trying to publish as much as I can to get folks the information that I think would benefit our U.S. healthcare system.
Well, appreciate the rigor that you're bringing to the table. Appreciate you asking people to put on their doubt hats until things get to a sufficient level of review. So very much appreciate that aspect of the conversation. And I hope that's resonated with the audience. Until we see you next time, thank you.